Hello guys, this is the second series of the most high yield concepts for the USMLE step 1, and in this video we will discuss the most or the top 45 high yield concepts in the neurology or the central nervous system. There is also some ophthalmology ideas and ENT also. So let's start. The first high yield concept is that amyotrophic lateral sclerosis will always be an old person, maybe 50, 60, presenting with pure motor lesions, either upper motor or lower motor, or usually it would be mixed in the exam. And if you see any sensation problem, you never break it because it would never present with a sensation problem. Okay. Now here is most of the diseases that affect the spinal cord. Poliomyelitis will cause ascending paralysis that looks like Guillain-Barré, but it would be asymmetrical, meaning in one leg more than the other one. Spinal muscular dystrophy will usually present with lower motor neuron lesion also, and it will present in a child with tongue fasciculations. Then we have the amyotrophic lateral sclerosis. It would be upper motor neuron lesion because it affects the corticospinal tract, then lower motor neuron lesion because it affects the anterior horn. Then tabes dorsalis, which happens from tertiary syphilis. This one would present with problems in the dorsal column tract. So they would present with ataxia, vibration, and proprioception problems, and they will present with Argyll-Robertson pupil, which is a pupil that can somehow accumulate but never react to light. Then we have subacute combined degeneration. I know the name is too long. It happens from vitamin B12 deficiency, and it would present with problems in the dorsal column, so ataxia, and also the corticospinal tract, so upper motor neuron lesion and spasticity. And the last one is that if the anterior spinal artery have been occluded, it would cause sensation problems and lower motor neuron lesions problems, but it would spare the posterior column, so it wouldn't cause an ataxia or problem in the vibration or proprioceptions or even fine touch. The next concept we have is that if a person is having memory loss and brought by a family member, then probably this memory loss is a genuine dementia, because sometimes the people think that they are losing memories and it's just normal age. Okay, if it's just a normal age, then it wouldn't be present by a family member. They will just come to you and tell you, I have a memory issue. Okay, now the most common cause of dementia is Alzheimer. The next important thing is that they will ask you which area of the brain is mostly associated for memory, and this is the area that's usually affected in Alzheimer. And the answer is the hippocampus, and this is the hippocampus here, because it can be asked on the step itself. Now, don't get me wrong, Alzheimer would cause atrophy to the whole brain, but it most commonly affects this area here, which is the hippocampus, okay? This is the thing. Another thing is that when Alzheimer atrophies, it will pull the ventricles toward it. So it would cause somehow a hydrocephalus, which is called the hydrocephalus ex vacuum, meaning it's not a real hydrocephalus. It doesn't happen from increased pressure in the ventricles. It just happened because the brain atrophied, so the ventricle somehow dilated to occupy the space of the brain. Okay. Now, the third concept is that amyloid precursor protein is a gene associated for Alzheimer. It's found on chromosome 21. And that's why people with Down syndrome, they have increased risk for it because they have 3 chromosomes of 21. Another thing is that they can ask you about the histology of Alzheimer. So you would see something called the hyperphosphorylated tau protein, okay, or neurofibrillary fibrillary tangles. It looks like a tangle here. Or you can see something called the senile belicks that's also made of amyloid. Both of them are made of somehow amyloid, okay? But this one is made of the beta amyloid. This one is made of hyperphosphorylated tau, okay? The fourth concept is that when you see personality change first, so the person is starting to gamble, starting somehow to have issues with his families, they never know him like before, then after that memory loss, then it would be called the Beck's body dementia or frontotemporal dementia. And it makes sense. Temporal, so it would cause memory loss. Fronto, so it would cause personality change. Now, the most important thing is that personality change precedes the memory loss. So it comes before memory loss, because you can sometimes confuse it with Alzheimer itself. okay? And this is here are Beck's bodies. They are just circular bodies that you can see in the histology, okay? The third or the fifth information is when you see personality change with myoclonus in acute duration, then it's called Creutzfeldt-Jakob disease, which is an infection, and it happens from a protein. So the protein is the infectious thing. And usually the infectious are usually like fungi, bacteria, virus, but in this specific disease, the infection is a protein, okay? And it can happen from neurosurgery, operations or whatever, okay? Now this protein, or what would you see exactly, is something called the vacuolization of the cells, meaning they will look very white like that. So it's kind of clear cell, looking like a lipid cell, if this makes sense, okay? And you would see elevated 14-3-3 protein, okay? And it's not hard to remember it. If I know that Creutzfeldt-Jakob is problem in a protein, it makes sense that I would see elevation of this specific protein. Like, I don't have to remember the numbers. I just need to know that there is elevation in a specific protein that has numbers on it. So if it comes in the exam, if it makes sense, okay? So they will present with you a person acutely because it's an infection. That's why it would be acute. So 3 months, he just developed personality change, memory loss, and then he's having a myoclonus, very important, okay? Then they will ask you what would be the diagnosis, Creutzfeldt-Jakob. The other important information is EEG findings. So you need to know 2 EEG findings on the exam. The first EEG finding is that in Creutzfeldt-Jakob you would see something called periodic sharp waves. They will not show you any EEG in the exam, but they will just say it on the vignette. The next important EEG finding is 3 Hz spike, which you usually see in silent seizures. When a kid usually has the silent seizures, he will just stare at the floor or stare at the wall and he will do nothing, okay? And you need to know that silent seizures itself are treated by a drug called isoxamide, okay? And this drug is important because this is the only drug that can treat silent seizures if it's isolated, not if it's mixed with another seizure. And this drug will work on the calcium channels of the thalamus. This high yield mechanism can show up a lot in the exam. So it works on the calcium channel on the thalamus, okay? Now, the next high yield thing is if you see personality change, most likely aggressiveness, with chorea, then you are talking about Huntington disease. Specifically, if they said also there is family history of this, for example, in the psychiatric facility or from suicide or from whatever, then it would be Huntington disease. Now, Huntington disease is autosomal dominant. That's why it would present with family history. And it's one of the trinucleotide repeat disorders. It's repeat in CAG, C-A-G. And it's a problem in the GABAergic neurons in the caudate nucleus. And this is here the caudate nucleus because they can ask you what's or where is the problem in Huntington disease. So the answer would be the caudate nucleus itself, okay? This is the important stuff. The next thing is when you see resting tremor in one hand, okay? So resting means it happens during rest, but it disappears when you go and grab something, okay? So when you go and grab something, it would disappear, but it would happen during rest, okay? So when you see resting tremor in one hand, plus rigidity, and sometimes monotonous voice, meaning so he speaks in monotony, he doesn't change his tone, okay? Then it would be Parkinson's disease, which happens from low dopamine levels in the substantia nigra, okay? And this is here is the substantia nigra. In the normal bubularity, it would be blackish like that or hyperpigmented, but in a person with Parkinson, it would be white or it would be pale, okay? Now, focus here that substantia nigra is found in something called the pars compacta, which is in the midbrain. This is the midbrain here, and I know this is the midbrain because I can see the cerebral aqueduct of Sylvius, okay, which is here, okay? This is small circle here, okay? The other important tremor is action tremors, meaning it moves while or it happens while I am moving my arm. Now, if they said action tremors self-mediated by alcohol, so the person drinks alcohol to relieve it, and there is positive family history, then the diagnosis would probably be essential tremors, which would be treated with beta blockers, okay? Because they can ask about the treatment. The answer would be beta blockers, okay? Okay, the next thing. When they say there is Parkinsonism with memory loss, early memory loss, okay, with REM sleep problems, okay, so maybe sleepwalking, okay, sometimes they will tell you also that this person is having hallucinations, then the diagnosis would be something called Lewy body dementia, okay, and in Lewy body dementia you will see something called eosinophilic inclusions, which looks very pinkish like that. That's why it's called eosinophilic, and it's also called alpha-synuclein. Okay, so you need to remember these things here. So when you see Parkinsonism with memory loss early, this is called Lewy body dementia, and you would usually see eosinophilic inclusions or alpha-synuclein. Okay, and this is the alpha-synuclein thing. Okay, now alpha-synuclein can also happen in the normal Parkinson. Okay, so it happens in both of them. Okay, the next high yield thing is that sometimes they will ask you about the neurotransmitters in a person with problem, or in a person with Huntington or Parkinson or Alzheimer. Okay, now what you need to know is that acetylcholine is always in equilibrium with dopamine. Okay, if dopamine decreases, acetylcholine increase. If dopamine increase, acetylcholine will decrease. Okay, and they somehow interact or counteract each other. So a person with Parkinson, let's start from Parkinson. We know that Parkinson have low dopamine. Then we would know that he is having high acetylcholine. Okay, then we know that a person with Huntington, we would reverse. So he will a person with Huntington will have high dopamine and low acetylcholine. And the last person is Alzheimer. A person with Alzheimer would present with low acetylcholine. Now that's why we would treat Parkinsonism with dopaminergic drugs or with muscarinic antagonist to decrease acetylcholine. And that's also why we treat Huntington with a drug that will inhibit dopamine secretion, because there is a lot of dopamine. This drug is called VMAT inhibitor, okay? And that's also why we treat Alzheimer with a drug that will increase acetylcholine. This drug is called donepezil, okay? And it will increase acetylcholine. So somehow, it wouldn't treat it, by the way, it will just somehow decrease the symptoms of it. It wouldn't change the course, but it would decrease the symptoms and the aggressiveness of the disease itself. Okay. The next important stuff is the dopamine pathways in general. Okay, so dopamine can act everywhere and do a specific function in each of its pathway. Okay, the first two pathways are mesocortical, mesolimbic. These are the ones that are abnormal in person with psychiatric problem like schizophrenia. Okay, now you need to know that antipsychotic will treat schizophrenia by inhibiting this pathway, mesolimbic. Okay, this is the first thing. So this is how antipsychotic treat schizophrenia. Okay. Then the third pathway is nigrostriatal substantia nigra. So this is the one for Parkinsonism. So this one is abnormal in Parkinsonism. Now antipsychotic are antidopaminergic. So if somehow by mistake they inhibit this pathway, they can cause Parkinson-like symptoms, like rigidity, for example. Okay. Now the last pathway is tuberoinfundibular. Infundibular meaning the infundibula is the one that connects the hypothalamus with the anterior pituitary. So tuberoinfundibular is the one associated with dopamine effect on prolactin. We know that dopamine inhibits prolactin secretion. Okay, this is tuberoinfundibular. Now this pathway here is the pathway that if antipsychotic somehow by mistake damage it, it would cause decrease in prolactin. It would cause decrease in dopamine, increase in prolactin. Then it would cause galactorrhea. Okay, galactorrhea. Okay. This is the dopaminergic pathways. Somehow they are important. Another thing is that sometimes they will ask you where is norepinephrine secreted, lucus coeruleus, in the bones. Okay, and sometimes they will also ask about where is serotonin is secreted. Okay, so just try to Google out where each neurotransmitter is secreted. Okay, if you have time. Okay. Okay. The other important concept is normal pressure hydrocephalus. Whenever they give you a person with memory loss, dementia, and ataxia, white gait, and urinary incontinence, this is usually normal pressure hydrocephalus. Okay, so memory loss, ataxia, urinary incontinence. These three symptoms are extremely pathognomonic for normal pressure hydrocephalus. Okay, okay. The last thing is the spina bifida. Okay. When you see there is a tuft of hair or lipoma in the low back of a kid that was just a newborn, then the answer would be spina bifida occulta, okay? And the spina bifida occulta, there is no herniation of the spinal cord, okay? But there is just like a birthmark to somehow tell the doctor that, okay, this is the diagnosis here. Now, any spina bifida can happen from a folic acid deficiency in the mother, which is vitamin B9, okay? Now, this is spina bifida occulta. We have meningeocele. Meningeocele would be just herniation of the meninges, okay? Just the meninges. Then we have myelomeningeocele, which is herniation of the meninges and also the myelin sheath, the nerves, okay? Of course, this one is the most severe, this one is mild. Okay. The next congenital abnormality is Chiari malformation and Dandy Walker. You need to know that Dandy Walker will be absent cerebellar vermis. There is absent cerebellum, okay? And there will be also hydrocephalus. But Chiari malformation, on the other hand, will just be herniation of the cerebellum, okay? Now, Chiari 1, only the tonsils of the cerebellum will herniate, and it would be associated with syringomyelia. But Chiari 2, the whole cerebellum will herniate, and also the whole spinal cord will herniate. So I just remember it by two herniations, the whole cerebellum and the whole spinal cord. So you would see myelomeningeocele, and you will also see herniation of the cerebellum, okay? But Dandy Walker, on the other hand, is absent of the cerebellum, okay? The last thing is that astrocytes are usually your way to go in any question asking about the nerve cells. Because astrocytes has a lot of function, like it forms a blood-brain barrier, it gets rid of neurotransmitters, whatever. But one of the most important function is that after cerebral infarction, it would cause something called the red neurons, which would happen usually 1 day, not 2 days, okay? After cerebral infarction. And after months of cerebral infarction, it will cause something called the galiosis, which is a substitute for fibrosis. Now, of course, we know that the brain is a permanent tissue, so it cannot regenerate. So it would heal by scar tissue. The scar tissue in the brain is called the galiosis instead of fibrosis, because we don't have fibroblasts in the brain. And the galiosis will also be formed from astrocytes. So whenever you see a person very early after infarction, the answer would be astrocytes, which would form as red neurons. But if you see it very late, the answer would also be astrocytes, okay? So astrocytes is your way to go. And as you can see here, this is the cerebral infarction. 1 day you would see red neuron, astrocytes. 2 days you would see neutrophils, like any other organ that can have necrosis and inflammation. Then you would see macrophage, then you would see galiosis at the end. Okay. The next thing is that multiple sclerosis is an autoimmune disease that affects middle-aged women, and it affects oligodendrocytes, which are the cells associated with myelination of the central nervous system, okay? Now, it happens as a remitting and relapses symptoms, so it comes as stages, and it will present with abnormal neurological symptoms, for example, hand weakness or whatever. But the most specific thing is that it will present with optic neuritis, which is muscle pain or eye pain during a muscle movement of the eyes, okay? This is the important stuff. But on the other hand, the Guillain-Barré, which is an ascending paralysis that happens after gastroenteritis or after infection, this Guillain-Barré affects Schwann cells, which are the cells that myelinate the peripheral nervous system, not the central nervous system, okay? And that's why Guillain-Barré would affect the peripheral nerves, so it would cause ascending paralysis from the legs, okay? Now, in Guillain-Barré, there is a high-yield concept you need to know, is that if you did a cerebrospinal fluid, you would see albuminocytologic dissociation, meaning there is a lot of albumin, but there is so little cells, okay? Or there is still so little biliocytosis, okay? And this is Guillain-Barré here, albuminocytologic dissociation, okay? The next concept is when you see a person having a stroke, and this stroke is affecting only one limb more than the other one, then you know that this stroke most probably happened in the cerebrum, okay? Because the way cerebrum is formed, or the way the cerebrum is formed, is that this is the homunculus here, and usually the face and the arm are lateral to the brain, and the legs are medial to the brain, so they are inside, and usually the artery that supplies this median side here is the anterior cerebral artery, and the artery that supplies the arms and the face is the middle cerebral artery, okay? So it's extremely hard if there is a thrombosis that would happen it would only happen in one of these arteries. So it would either cause only leg problem or only hand or face problems, okay? It wouldn't cause the two problems together. If it caused the two problems together, then you think outside of the cerebrum, because the cerebrum arteries can never cause the specific symptoms where it affects the two limbs together, okay? Now, the middle cerebral artery would be the one associated with hand and face problems, but the anterior cerebral artery would be the one associated with legs problems, okay? The next thing, if you see a person having a crossed lesion, meaning left face problems and then right body problems, then you know that you are looking at the brainstem. There is brainstem lesion, maybe medulla, maybe bones, maybe midbrain, I don't know yet. But you need to know that when you are looking at a crossed lesion like that, this is usually a brainstem lesion, okay? Now, how do I know if it's lateral, bones, medial medulla, or whatever? Depending on the cranial nerve. This is the most important step. If you are talking about cranial nerve 3 and 4, you are in the midbrain. If you are talking about cranial nerve 6, then you are in the middle bones, or medial bones. If you are talking about cranial nerve 7 and 8, then you are in the lateral bones. If you are talking about cranial nerve 12, you are in the medial medulla. And the cranial nerve 9, 10, 11, you are in the lateral medulla. Just like that. So we would read and we would see, okay? For example, if they say there is crossed lesion and there is 9, 10, 11 cranial nerve affection, for example, most probably dysphagia or hoarseness of voice, then you know that you are in the lateral medulla. So there is lateral medullary syndrome, which is BICA, posterior inferior cerebellar artery, okay? Now this is the rule of 4 here if you just need to remember the rule of 4, but this is the easiest way to just know it, okay? This is the easiest way to know it. Of course, we know that any medial structure will start with M, any lateral structure will start with S, okay? So for example, the middle meniscus, the motor busway will be medial, but the spinothalamic spinocerebellar will be lateral, okay? And the sympathetic, for example, okay? Now, if you see crossed lesion with cranial nerve 12 affection, then it would be medial medullary syndrome, which is usually occlusion of the anterior spinal artery. So the way it works is that this is the spinal cord, and then we have the medulla. So medulla, in the middle part of it, it's also supplied by the same artery that supplies the spinal cord anteriorly, which is anterior spinal artery, okay? So anterior spinal artery occlusion would cause medial medullary syndrome, okay? Now, if you see crossed lesion and the 5, 7, and the 8 cranial nerve affections, so for example, there is facial palsy because cranial nerve 7 affects the muscles of expression, okay? So it would be facial palsy like that. Or for example, there is hearing loss because cranial nerve 8. Then you know that you are looking at lateral pontine syndrome, or ICA, anterior inferior cerebellar artery, okay? The last one is if you see quadriplegia, and the person cannot move his eyes horizontally, but he can also move it vertically. So there is literally complete paralysis, okay? And he can only move his eyes vertically. Then you are looking at a disease called the locked-in syndrome, which is the median pontine artery syndrome, okay? Or it affects the median pontine, it affects the median pontine lesion, which is a problem in the basilar artery. Because basilar artery usually supplies the pontine or the bones medially in two ways. And when it somehow affects the bones, it will damage the motor nerves. We said M is in the medial side. And it will damage all the motor innervations to all the body. So he will literally have complete paralysis except in the vertical movement because it's supplied or it's before the bones itself, okay? Now this locked-on syndrome thing can happen also from rapid correction of hyponatremia, okay? And this is important. And this is here. Is the myelinosis that can happen from rapid correction of hyponatremia. It's okay, and I think it's called the cerebral pontine myelinosis or something like that. Okay. The next extreme high yield concept is when you see oculomotor nerve palsy, which is outward and downward eye, and they ask you what can be the cause of it. Most probably it would be posterior communicating artery aneurysm or posterior artery aneurysm, or ankle herniation. Or they can invert the situation. They can tell you, for example, a person is having a herniation and then there is oculomotor nerve injury. And they will ask you what type of herniation is this one? Is it sagittal, is it ankle, or whatever? So the answer is ankle herniation, Okay. Now, also oculomotor nerve injury can happen from diabetes, because diabetes affect the micro vessels that innervate the nerves, but it would be motor only before it affects the parasympathetic. So it will probably be outward and downward eyes, but without causing the dilation or the problems in the pupil itself. Okay, this is the thing. Okay. The next extreme high yield concept is tongue innervation. You need to know that tongue innervation motorly will be cranial nerve 12. That's why we said when a person is having tongue deviation, then we know that it's a cranial nerve 12 affection, then we know it's a medial medullary syndrome. Okay, so most of the motor would be cranial nerve 12. Okay, now the anterior 2/3 of the tongue, if it's normal sensation like pain and temperature, then it's the trigeminal nerve. But if it's a taste, then it's facial nerve. Now it's not hard to remember, because I know that trigeminal nerve affects the sensation of the whole face, and also the anterior 2/3 of the tongue, and also the muscles of mastication. So it's not hard to remember that this is the one that would give also the normal sensation to the anterior 2/3 of the tongue. But when you are talking about the posterior 1/3, then it's either cranial nerve 9 or 10. If it's uvula, it's probably 10, vagus. If it's just the posterior 1/3 of the tongue, then it's probably glossopharyngeal. Okay, so motor 12 all the tongue, anterior 2/3 will be 5 trigeminal if it's a normal sensation, it will be 7 facial if it's taste sensation. Posterior 1/3 sensation in general, either taste or normal sensation, it would be 9 and 10. Okay. The next concept is the cranial nerves reflexes. Sometimes they will ask you what are the afferent and the efferent of each cranial nerve reflex. The first one is corneal reflex. So what is corneal reflex? It's when you touch the cornea, your eyes will close. Now, very easy. You touch the cornea. What nerve supply all the sensation in the face? We just said it. Trigeminal. So the afferent when you touch is trigeminal. Now you close. How do you close? Muscles of expression. I'm expressing. So you would close with cranial nerve 7, facial. So the afferent would be 5, the efferent would be 7, okay? By the orbicularis oculi muscle. Okay. The jaw jerk. Here is the thing. In the jaw jerk, you would tap in the jaw can open or deviate. Now here's the thing. You tap, again, sensation. So we know the afferent already, 5, again, 5. Any sensation in the face would be 5. Now, when you open the jaw or move the jaw, this is muscles of mastication, which is 5, not 7. 7 is muscles of expression. 5 is muscles of mastication. So the afferent is 5, the efferent is also 5. This one can be confusing. So the afferent is the same as the efferent, 5 and 5, okay? The jaw reflex. Okay, gag reflex is 9 and 10. Okay, this is the gag reflex. When you somehow put your finger so you can induce vomiting when you are blackouting or something. And the last one is pupillary reflex or light reflex, which when you direct a light, then you would see the light. So the afferent would be cranial nerve 2, the optic, of course, because you would see the light by the cranial nerve 2. Then responding to this light, but your eyes, pupils will constrict. Constrict by what? By the oculomotor nerve. So the efferent would be 3. Okay? Okay. Now another important stuff is the dermatomes. I need you to remember that thumb is 6, then the middle fingers would be 7, then the pinky will be 8. They ask you about it a lot. So thumb 6, middle fingers 7, pinky 8. Okay? I need you also to remember the biceps reflex C6, C5, the triceps C6 and C7. Okay? And the last thing that I need you to remember is the knee reflex L2, 3, 4. Okay? And you also need to know that S1 would be the ankle reflex. Okay? If you can remember the L innervations in general, like the shape of them, I would also appreciate it, because somehow they can also appear on the exam. Okay? Okay. The next concept is the hematomas. So this one here is the epidural hematoma. It happens from injury of the middle meningeal artery, and it happens during a trauma, and the person will have lucid interval sometimes at first. So he will have asymptomatic interval first, so you have to hospitalize him. The next one is this one here, which is the subdural hematoma. And now, as you can see, subdural is diffuse like that. It's crescent in shape. But epidural is having a specific limitation by sutures, okay? Now, subdural is problem in the bridging veins. Now, it can happen in elderly, because we said in elderly, the brain somehow atrophy. When the brain atrophy, it can pull the bridging veins and shear them out, so injure them. And it also happens in baby, when the father, for example, try to play with the baby, his face can shake out, or his head can shake out, and it can cause also shearing of the bridging veins. So it can happen in babies and elderlies, and it's a problem in bridging veins. Okay. Then we have the subarachnoid hemorrhage. As you can see, it looks like a sulci, okay? Sulci hemorrhage, okay? And this one would be presented as the worst headache of my life, and yellow cerebrospinal fluid. So the cerebrospinal fluid will be yellow, okay? And also hypertension, by the way. Now the cause of it is saccular aneurysm, okay? Saccular aneurysm, okay? Sometimes also perianeurysm. So you would see a person with Marfan, for example, or collagen disease, maybe Ehlers-Danlos or whatever, and then this person present with brain hemorrhage, and you would see this picture, and they will ask you what type of brain hemorrhage. The answer is subarachnoid hemorrhage. Okay. The last one is intracranial hemorrhage. I need you to know that if this intracranial hemorrhage happens in young people, the answer would be that this person have arteriovenous malformation. Arteriovenous malformation. Okay. Arteriovenous malformation. Okay. And the next high yield concept is Broca and Wernicke. So if Broca has been damaged, I can see here this is in the frontal area, so it's motor. So the person will not be able to talk, but he can understand you well, but he cannot talk. So if you told him to open the door, he will open it, but he cannot talk, so he will just try to, but he can't talk, okay? Wernicke, on the other hand, cannot understand anything, and he can talk, but his talking has no meaning because there is no understanding at all, okay? So if there is Wernicke problem, he can talk because Broca is intact, but his talking has no meaning. For example, car elephant in the room, car elephant in the salad, whatever. Like his words or his wording doesn't have any meaning at all. This is Wernicke, okay? And you need to know the locations on both of them, high yield for the exam. Okay. The last thing is the types of headache. This is just the normal tension headache. They will not ask you about it, but they will ask you about this one, which is cluster headache. You will see a man. This man is having periorbital pain, or retroorbital pain, so pain behind his eye, or headache behind his eyes, and they will ask you about the treatment, and the answer is 100% oxygen. Okay, so you give him oxygen. On the other hand, this is migraine. Migraine will be present with aura, then unilateral pulsatile headache. Now the aura would usually be photophobia, okay? So he's afraid of light. Phonophobia, he's afraid of sounds, okay? Or sounds exacerbated, okay? Now what you need to know about migraine is that you treat it acutely with non-steroidals and triptan. But if you need to prophylax it, you would give beta blocker, okay? And now they can ask also about the gene in migraine, which is calcitonin gene-related peptide. Sometimes they will ask about this gene, calcitonin gene-related peptide, and it has nothing to do with calcitonin, the hormone. Okay. The last one is trigeminal neuralgia. There is usually a micro obstruction of the trigeminal nerve or the blood vessels to the trigeminal nerve. As you can see, the blood vessel somehow can obstruct the trigeminal nerve or press on it, and that would cause neuralgia because we know the trigeminal nerve affects the whole sensation of the body or the face, right? Now, it would present when you trigger it. So when you tap on it, when you brush your teeth, okay? When you try to eat, you will see pain. Now, what type of pain? Electrical shock sensation, because this is neuropathic pain. It happens from nerve problem. Now, this is different from jaw claudication, which happens in giant cell arthritis, which would be an old woman with fever, systemic symptoms, temporal artery problems, maybe blindness, whatever, okay? Both of them are different from each other, okay? Now, you treat trigeminal neuralgia by carbamazepine, okay? The next concept is cerebral aqueduct of Sylvius, is the most common cause of or stenosis of cerebral aqueduct of Sylvius is the most common cause of hydrocephalus in kids, non-communicating hydrocephalus. So what is non-communicating hydrocephalus? It's when the person have elevated intracranial pressure because the ventricular system somehow is stenosed, so it's not connecting with each other, not communicating, okay? And the most common cause again in kids is congenital stenosis of the cerebral aqueduct of Sylvius, okay? This is important, okay? Then let's discuss the tumors, okay? Now, one of the most important tumors is meningioma. Meningioma is malignancy of meninges, of course, so it would be outside of the brain, in the meninges. Don't confuse it. Don't say, oh, it's inside the brain. No, it's outside, but it's pressing on the brain, so somehow it pushed through the brain itself. And this is the radiology of meningioma, okay? Now, meningioma with M happens in mothers, so it happens in females, and also associated with estrogen females, okay? And you would see some moma bodies on the histology. This is some moma bodies here, which is calcifications, okay? You can see it in a lot of tumors. For example, papillary thyroid carcinoma also, right? Okay. The next thing is glioblastoma. This is the highest malignancy in adults, or the poorest prognosis of malignancies. And you would always see that it crosses the midline. So as you can see here, there is necrosis here, and there is necrosis here. So it crosses the midline, okay? And it's GFAP positive. And what you would see in the histology is pseudo-palisading. So palisading means that there are cells that are somehow gathering around something. Now the thing that they are gathering around are necroses. And that's why it's called pseudo-palisading, which are cells gathering around the necrosis. Okay? This is glioblastoma multiforme. The next tumor is oligodendrocytoma. This is a tumor of the frontal lobe, and it's a tumor of oligodendrocytes, and you would see fried egg appearance, okay? Just about it. And the other one is schwannoma. Schwannoma is a tumor of Schwann cells, which are the peripheral nervous system. And sometimes it happens, or usually it happens in the cerebellopontine angle. Now remember, the pontine, in the site, what type of cranial nerves exit from it? Cranial nerve 7 and cranial nerve 8. So if the tumor happens here, it can cause 7 and 8 cranial nerve problems, okay? Now, schwannoma is usually associated with neurofibromatosis type 2. This is important. Neurofibromatosis type 2, okay? And it's S100 positive because it's derived from the neural crest. Any cell that's derived from neural crest will be S100 positive. Melanoma is S100 positive. Histiocytoma, Langerhans cells, the histiocytoma is also S100 positive, okay? So this is schwannoma here, very important. Okay. The next one is craniopharyngioma. This is a tumor in childhood, and it presents as cystic calcifications and cholesterol crystals and calcifications, okay? Now what you would ask about is that it's derived from Raschke pouch. Now how would you see it in the exam? It would cause the same symptoms of pituitary adenoma, bitemporal hemianopsia plus headache, okay? This is here craniopharyngioma. They will ask about the Raschke pouch, high yield. Okay. The other two childhood tumors are tumors in the cerebellum. We have medulloblastoma, which would present as blue cells like that because they are primitive cells. Okay, cells. And you would also see homarite rosettes. You would see rosettes, okay? It looks like the pseudo-palisading that we have seen in glioblastoma multiforme. But glioblastoma is in adults, this one is in kids, okay? The other one is biliocystic astrocytoma. This is here biliocystic astrocytoma, and you would see these fibers here. They are called Rosenthal fibers. Okay? Okay. The next concept is ataxia. When you see a person have ataxia plus heart failure plus scoliosis plus diabetes mellitus, this is Friedreich ataxia, which is trinucleotide repeat disorder in GAA, okay? And just remember gait, okay? So GAA, gait ataxia, okay? There is problem in the gait, okay? Now, it's a problem in a Friedreich so it's a problem in FE, iron metabolism, in the ferratoxin gene, okay? So it's a problem in the iron metabolism, okay? Now, don't confuse it with something called ataxia telangiectasia. Ataxia telangiectasia is problem with immune dysfunction, and you would see telangiectasia, of course, associated with ataxia, and also tumors, lymphoma and leukemia. And this ataxia telangiectasia is problem in the ATM gene, which is associated with repairing double-stranded DNA, okay? Both of them are different. So this one is ataxia telangiectasia, this one is Friedreich ataxia here, okay? Now let's discuss some ophthalmology. So when you see a person in the emergency department with sudden acute pain in the eyes, with fixed mid-dilated pupil, this is acute angle closure glaucoma. And it usually happens from anything that can dilate the pupil. So for example, if you give the person atropine, or if he enters the cinema, for example, or a dark place. If you enter a dark place, your sympathetic will be activated, it can cause dilation, okay? And this acute angle closure glaucoma, in order to treat it, you need to give a person some drugs that will constrict the pupil, okay? And that would also decrease the pressure inside the eye. For example, acetazolamide, very important. You would also give him beta blocker, inhibit the sympathetic. So you would decrease the aqueous humor, and you would also cause constriction of the pupil, okay? Muscarinic agonist would also cause constriction of the pupil, okay? Okay. The next one is sudden loss of vision. When you see sudden loss of vision for seconds, then the person somehow retain vision again. This is called amaurosis fugax. Amaurosis fugax. And it happens from transient ischemic attack, okay? This is amaurosis fugax, okay? But when you see just a sudden loss of vision, but there is no return of vision, then you would suspect thrombosis of the blood vessels. If it's a thrombosis of the artery, you would usually see a pale retina and a cherry red spot here. And the reason for that is thrombosis of the artery will prevent the blood to go into the retina, so the retina will be pale. Now, how about the macula? Why the macula is still red? Because the macula receives double blood supply. Okay. But if there is venous thrombosis on the other hand, you would see that the retina becomes very red, because blood can go from the artery, but because there is venous thrombosis, blood will enter and cannot exit, so it will accumulate in the retina, if this makes sense. Okay, so you would see red retina. Okay, now this cherry red spot can also be seen in lysosomal storage disease, right? You would see it in Niemann-Pick, and you would also see it in sphingomyelin or sphingomyelinase deficiency, right? And usually the difference between them, Niemann-Pick and GM2 deficiency, which is usually called, I don't remember the name of it, but whatever, like Niemann-Pick will usually be associated with this splenomegaly, hepatosplenomegaly, and the other one, which is Tay-Sachs, would not be associated with hepatosplenomegaly, and the both of them would be associated with cherry red spots. Okay. The next concept, when you see floaters, then sudden loss of vision, this is usually retinal detachment. So you would see flashes of light and the floaters, then sudden loss of vision, this is retinal detachment. Okay. Myopia is a risk factor for retinal detachment. Okay. Another thing, if you see a person is not reading like he used to do because he is aging, so with age he cannot read as well, this is called the presbyopia, which is normal age-related problem because of a problem during accommodation. Okay, so he will have to keep the book far from him because he cannot accommodate when he get it close to his eyes. Okay, another thing, when you see an elderly person that cannot hear, specifically high frequency volumes, this is also a normal problem with aging, and it's called presbycusis. So presbyopia is vision problem with age. Presbycusis is a hearing problem with age. They always love to ask about aging in the USMLE. Okay. The next thing is when you see vertigo. If you see vertigo for only seconds or 1 minute, 2 minutes maximum, this is called the benign paroxysmal positional vertigo. And it's usually a problem that there is some sands or sand-like particles here that's causing this vertigo, and you would treat it with something called Dix-Hallpike maneuver, which would usually be that you would turn the person's head and these particles will somehow go into its own place or whatever. Okay, now this is an opposite. When you see vertigo for hours to 24 hours maximum, this is called the Meniere's disease, which is problem in the endolymph. There is increase in the endolymph. Okay, both of them are different. So if it's a vertigo for seconds, this is paroxysmal. If it's vertigo for hours to 24 hours so 1 day maximum, this is Meniere's disease. Okay, another important thing in the ENT is the anatomy. They love to ask you about the maxillary sinus and that it will drain in the middle meatus. Okay, just remember M with M. and that they will always love to ask you about the lacrimal duct. The lacrimal duct will drain into the inferior meatus. Okay, so maxillary sinus middle meatus, lacrimal duct inferior meatus. Okay. The next important stuff is when you see leukocoria in a kid. Now leukocoria is that when you somehow photograph the kid, or when you photograph yourself using a flashlight, usually our eyes appear red, right? And the reason for that is that light will enter and then it will somehow reverse the red color of the retina, so our eyes will appear red. Now if there is problem here that's preventing light from entering, it will cause leukocoria. Now the problem there can be two problems in kids. The first problem is retinoblastoma, which is the most dangerous problem, okay? And you always need to exclude retinoblastoma in a kid that have leukocoria. Now remember that retinoblastoma is always associated with osteosarcoma, which is the malignancy of bone. So you have to exclude both of them. The next thing is you exclude cataract. Now cataract in kids can happen from two important reasons. There is a lot of reasons, but the most two important ones are galactose metabolism problems, so galactokinase, GB1 UDP deficiency, and also rubella. Rubella can cause cataract. Remember our first video, we said rubella would cause cataract and the patent ductus arteriosus. Okay. Now our last information, I know it's a lot, is a drug information. Okay. Barbiturate, usually with benzodiazepine, work on the GABA channel. GABA channel is usually inhibitory channel. So that's why barbiturate and benzodiazepine are relaxants, okay? Now barbiturate will increase the duration of this channel. And the way you remember it, barbiturate. But benzodiazepine will increase the frequency of this channel, okay? Now remember that both of them will work on GABA. Also alcohol, which is also a sedative, work on GABA. Now GABA B on the other hand is targeted by another drug called baclofen, extremely high yield. And this drug, when it agonizes GABA B, it will relieve muscle spasticity. We can use it for spasticity and also multiple sclerosis. Okay? And this is it. Thank you guys so much for watching and good luck with your exam. If you need anything, you have my contact and just contact me. Bye bye. Bye bye.